Good morning, everybody. I hope you can hear me well. Thank you for inviting me. Today, I will talk about the difficulties we face in diagnosing delayed cerebral ischemia. There is nothing to declare. Fischer and his group were the first who described that the amount and distribution of aneurysmal subarachnoid hemorrhage corresponds well to the later on seen location of high-grade vasospasm. In our days, CT perfusion is easy accessible. We therefore often forget the computational underlying post-processing. SAH patients often need an EVD or even an invasive neuromonitoring. Coils and clips that are needed to treat the bleeding aneurysm are a major source of artifacts, and they are prone to error. Intracranial hemorrhages and brain swelling often lead to hemicraniectomy. Delayed cerebral ischemia occurs in 20 to 30% of patients suffering from aneurysmal subarachnoid hemorrhage, and it's the major source or the major reason of poor neurological outcome. The diagnostic criteria of DCI include a focal or global neurological impairment that lasts at least 1 hour, or a cerebral infarction that can be identified in CT or MRI more than 48 hours after the initial subarachnoid hemorrhage occurred. Delayed cerebral ischemia is a multifactorial disease. It includes a disruption of the autoregulation, early brain injury, inflammatory reactions, microthromboembolism, micro and macro vasospasm. Our work group described a new classification of cerebral vasospasm according to the location of vessel narrowing seen on DSA. Cerebral vasospasm is a bilateral pathology. It occurs in the anterior circulation mainly. It rarely affects the vertebral-basilar system. The vessel narrowing spreads from the distal to the proximal arteries, and it mainly affects the anterior cerebral arteries. The prolonged muscle cell contractions can last over days. Therefore, we see a widening of the peripheral arteries, as you can see here in the M3 and M4 segments of the MCA. We have a development of huge collateral supply to the ACA territory, and we have a shift of the border zone to the midline. Here you can see a typical finding of a CT perfusion of a patient who is suffering from high-grade ACA vasospasm. We see that there is tissue at risk of hypoperfusion in both ACA territories. There is a preserved relative CBV and a decreased CBF. The time parameters are prolonged. And you can see that the oxygen extraction is highly elevated, and we have a heterogeneous capillary transition. This patient underwent intra-arterial spasmolysis with nimodipine immediately after diagnosing these vasospasms. In the follow-up CT, you can see, so you cannot because of the light, I will explain it. You can see that there are embolic infarctions in both ACA territories, affecting the sensory cortex as well. We cannot see a huge territorial infarction, but affecting the sensory cortex is really something impressive. And would it not have been better to treat this patient before this huge perfusion deficit occurs? And what really says if an infarction occurs or not? I will show you the next case. This is a very young lady of 32 years, 5 days after the initial subarachnoid hemorrhage occurred. With the help of the maps that don't have that much artifacts anymore and the new maps, you can see that there is an elevated oxygen extraction fraction in the border zone. And you can see that there's already a heterogeneous capillary transition, and you have an elevation in the time parameter. So there is already a hyperperfusion going on in the border zones. 2 days later, this even aggravated. You can see that this patient now is suffering from a high-grade vasospasm in the anterior cerebral artery territory on both sides. But what is different to the patient we have seen before? In this case, you can see that you have a clear hyperperfusion of the posterior part of the ACA territory and of the PCA, the posterior cerebral artery territory. This patient had the time to develop collateral supply through the vertebral basilar system. This patient didn't undergo an intra-arterial spasmolysis, but an induced hypertension. As you can see now in the follow-up, this patient didn't develop a huge territorial infarct. You can see that there's only a small embolic infarct in the anterior cerebral artery territory in the frontal part of the left side. Not as bad as the last one. I'll show you the next case. Here you can see that this patient also developed a collateral supply of the vertebral basilar system. He suffers from really high-grade vasospasm, affecting the anterior circulation with the ACA and the MCA territory, the border zones. If you go to the inferior slides, then you can see that there is a hyperperfusion of the cerebellum, of the thalami, and there's even a better perfusion of the basal ganglia. High-grade vasospasm affects the intradural ICA, the MCA, and the ACA. As you can see in this diagram, you have a delayed filling of the ACA territory, and you have a prolonged standing of contrast in the parenchymal phase in this territory. The ophthalmic artery defines the border between the intradural and extradural ICA. As the blood cannot really go into the ICA territory anymore because of high-grade vasospasm, it needs another way to leave the brain, and it takes mainly the ophthalmic artery and its branches. And it's a prolonged process. Therefore, the arteries can become hyperplastic. And when you see the supratrochlear artery on an angiogram, it predicts a really bad outcome for patients who are older than 50 years. You can even see this hyperperfusion in measuring ultrasound in the supratrochlear artery. We started to compare control patients, datasets of control patients, and SAH patients, and we saw that there is an increase of RCBF in patients suffering from SAH, even more in the contralateral side of the bled aneurysm. This is the site that we normally use for our baseline in all algorithms. When the intracranial pressure increases, the mean arterial blood pressure needs to be elevated too, to preserve the cerebral perfusion pressure. SAH patients often undergo a self-induced or medication-induced hypertension. Therefore, if the autoregulation would be intact, proximal vasoconstriction would occur and the RCBV would be decreased. These are the requirements of our days for CT perfusion. And the most important innovation of our days is CT scanners who have a whole brain coverage of 8 centimeters. In nowadays, a lot of CT scanners exist that only have an axial coverage of 4 centimeters. Therefore, it is needed that a scanner moves in between the measuring to expand their brain coverage. If the temporal resolution is longer than 3 seconds, you cannot gain really values, like real values, for reference values. It is possible that you can compare both sides to each other, like inter-side comparison. But if you want to gain real reference values, you need a whole brain coverage. That is really the fact why we don't have real reference values for patients suffering from DCI in our days. This review summarized all prospective and retrospective studies who tried to find thresholds in early and late CT perfusions that may help to diagnose DCI in patients who are suffering from aneurysmal subarachnoid hemorrhages. But as you can see, they all were focusing only on hypoperfusion. That's maybe the reason why all these studies did not significantly correlate with the later on seen DCI. As you all know, the delayed cerebral ischemia is a multifactorial disease. If a lack of ATP occurs due to the prolonged muscle cell contractions, the neuronal depolarization is impaired. Therefore, a spreading depolarization occurs, which is seen as a spreading depolarization through the gray matter. The healthy brain tissue, therefore, will elevate the RCBV to raise the increased amount of energy. This process only lasts for a few minutes, but if the depolarization is prolonged and that it doesn't stop, then we have the problem that it becomes a spreading ischemia with an increase of RCBV due to vasoconstriction. And you will see delayed cerebral ischemia as well. This patient clearly shows that you can have tissue at risk of hypoperfusion in the MCA territory, but you can also have tissue at risk of hyperperfusion in the anterior and posterior circulation, not in the frontal ACA territory. And you can clearly see in the follow-up CT that both are interesting and both matter, because both developed delayed cerebral ischemia. CT perfusion has a lot of advantages and gives us a lot of information. Besides the radiation dose, we can really get a lot of information, which is not seen in all the other monitoring methods that is given in these days. Due to hypoperfused areas, we get an idea of the vasospasm, the cerebral vasospasm, the grade, and of the disruption of the microvascular. We can even get an idea about the collateral supply, as I showed you. And if we see areas of hyperperfusion, we can get an idea of the cortical spreading, depolarization, and even occurring seizures. So one day, if we all are using scanners with a whole brain coverage, my dream would be to get the following information of artificial intelligence from a CT scan. The plain CT scan should tell me which is the amount of an intracranial hemorrhage, like the volume. I would like to know what is the modified Fisher score of the patient, and does he need an EVD. In the later on follow-up, I would like to know, is there a new infarction? Did it occur because of the treatment, or is it a delayed cerebral ischemia? And I would like to know if the treatment of the hydrocephalus is sufficient or not. From the CT perfusion, I would like to know a lot of things. But in these days, we're facing the problem that we don't have reference values really. So it might be necessary that we all need to gain like a baseline parameters that we compare to the later on follow-up to have an idea if there is already tissue that is hyperperfused or hypoperfused. And we can get an idea of the collateral stages of the patient, because I showed you there was a patient that underwent intra-arterial spasmolysis that developed infarctions, and I showed you a patient that did not undergo this excessive treatment, only treated with induced hypertension, who did not develop such amount of infarctions. And we really need to figure out which patient needs an aggressive treatment and which one is able to overcome this cerebral vasospasm and all these changes alone. Thank you for your attention. I'm now happy to get your questions.
Thank you so much for very instructive. Are there
Because the problem is, it's the images is nice, but we need to know how to treat the patient based on the image you're getting.
Exactly.
So my question is, has this changed anything?
So in our clinical practice, it didn't change that much because we we had a cut like 3 years before. We were treating all patients who were showing with a cerebral vasospasm, who had a perfusion deficit with interarterial spasmolysis.
So you do spasmolysis?
We did spasmolysis. And then 3 years before, a new neurosurgeon was coming to our institution. And we were facing the problem that we could only do induced hypertension anymore. But nowadays, I have like a patient collective that is only treated with intra-arterial spasmolysis, and I have the second one that is only treated by induced hypertension. So before, I was not able to see which patient is able to overcome this period alone, which doesn't need an intra-arterial spasmolysis, because we were treating them all. And now I have a collective where I can have a look in what determines if this patient overcomes it alone and what was the one where we should have treated it better. So I guess I will start to compare these both groups and try to find really things like the collateral status that really determines this patient does only need induced hypertension, because if we give intra-arterial spasmolysis, if we perform balloon angioplasty, all this interventional stuff, we should face in the same moment the problem that we have side effects. We have side effects that this patient needs more vasopressor demand, like all these medication. It doesn't only act local, it acts systematically. And in this way, we all get the bad side effects if we overtreat a patient. But there are some who are not able, and we really should treat them. And my opinion is, I'm an interventional neuroradiologist. I love treatment. I want to perform an endovascular treatment, but I should have a closer look on the patient who really needs it and who doesn't.
Thank you. Other questions? I think there was one there.
Thank you very much for your nice presentation. So do you find or search any correlation between hypo or hyperperfusion in CT scanner, because you cannot perform it every day, between electrophysiological monitoring or Doppler monitoring?
Yes, it's an interesting question. So we are trying to set up a study with another hospital where we want to have this frontal EEG, like this monitoring that is done all day long, and you can see electrically changes of the patient, and we want to correlate it with a CT perfusion if you can see it in the same time. We don't have this invasive EEG monitoring that would be needed to confirm if this hyperperfusion, what you already saw, is due to seizures or is due to cortical spreading depolarization. I think it's a kind of electrical changes, but we have to more declare which kind it is. And therefore, you really need, the ethics, you need a prospective study. That's not so easy done, but this is something I really want to do in future.
Do you have some routine protocol? Because sometimes patients are still on respirator assistance to perform CT perfusion. You perform it systematically at
So
7 days or?
yeah, it's in unconscious patients. We perform it on day 7 or 9 now, but I try to convince my neurosurgical colleagues that we have to start with a CT perfusion on day 1, as long as we don't have these reference values. And we have a scanner that has a 4 centimeter coverage and one that has an 8 centimeter coverage. So it's really important to shift them all to the scanner that has this 8 centimeter coverage. And to just work on one scanner. That's the first thing. And then to get like reference values, all that like a subarachnoid hemorrhage and the late cerebral ischemia, it's not like a stroke. You have not this huge amount of patients. It's really hard. You always work with retrospective things you have and to figure it out. Yeah, so you need protocol at I guess the 7th day is the best, and then if you see something, you really have to repeat it if it's an unconscious patient.
Do it on day 1 and day 7.
Yes, I would.
Thank you.
But I guess there are some people here who already have a set up protocol for CT perfusion. Maybe they want to share their opinion and their protocols.
For your presentation, which parameter you found the most useful for predicting vasospasm and delayed cerebral ischemia in your experience?
You mean to see like early changes?
Yes, yes.
Yes.
When
So if I have a closer look, like I showed you the patient who was very young and the CT perfusion of the 5th day and the 7th day after subarachnoid hemorrhage, it's easier for me to see it in the oxygen extraction fraction. It easily shows that there's something going on. You have the you can see slight changes, and then you have a closer look in the other maps. Like the CBF won't show it to you. I cannot see it really good, but the oxygen extraction fraction and the CTH will show it to you. I can see it easier. Yeah, so in MTT you can see it as well, but I see it. I had patients where I could see a change only in the oxygen extraction fraction, only in CTH, and not that much in the other time parameters, because it's like a standard deviation, and you can see it more. Like I think it's a better map to get in these really early changes.
There's a question down at the back. Artu?
What do you think about MRI perfusion versus CT perfusion for these patients?
For subarachnoid hemorrhage?
Yeah.
Yeah, so there's a clear problem in the clinical way you can do it, because it depends on how much MRI capacity you have. I would love to do an MRI for every SAH patient. I really would love to, but it's a matter of time. It's a matter of the capacity, how much MRI scanners you have, and I think it's the better way to do it. If you have a whole brain coverage, you don't have to think about getting reference values. You can easily get them. But the problem is here that not every clinic can perform an MRI. And it would be even better for the radiation dose. I mean, you have no, so you can perform it as often as you want, and you don't have to be worried about this.
Thank you for great talk. question here.
Hi. Sorry, I didn't see you.
I have a question about the delayed cerebral ischemia. Actually, I'm wondering, so what is the underlying mechanism between neuron, swelling neuron, and exercise
Yeah.
to make spreading depression? Something?
Yeah. So I didn't go really into detail to this. I just said that an ATP lag, because of the energy demand of these prolonged muscle cell contraction, will give you difficulties for the repolarization of the neurons. But what I really think is everybody has heard something about the glymphatic system nowadays, I guess, and about the brain clearance. And you have a subordinate hemorrhage that is really dramatically damaged to the subordinate space. And so I guess in some way the brain clearance is disturbed by maybe erythrocytes entering these perivascular spaces because of the high pressure you have. I mean, there's a border between the perivascular spaces and the subarachnoid space. So it's not the same, the CSF fluid and the perivascular fluid. But if you have a high pressure, it is maybe easy, this small border of small cells to interrupt it, and you have erythrocytes entering these perivascular spaces. Then you have a real problem in the fluids that need to be exchanged all the time to have a brain clearance, a really good one. I'm always wondering why the cerebral vasospasm and all these things, like the cortical spreading depolarization, occur so late. Why it happens at day 5, at day 7? Why it doesn't happen immediately? And there needs to be an underlying cause, like the brain clearance is really impaired. There's something going on in the wall of the vessels that lasts at least a few days until it becomes really worse. And we all know that the aquaporine 4 channels, they are really active at night. You have a nice clearance of the brain. And if this is really disturbed, like drinking too much alcohol, not getting enough sleep, we all feel really bad. We cannot think anymore, really. And if you meet a patient who was suffering from subordinate hemorrhage, you meet him 6 months afterwards, then they all say, I have so much problems in my short-term memory. I cannot really remember the easiest things sometimes. And it's already in the research that dementia and things like this, they all correlate with a disturbance of the glymphatic system. So we should really think about becoming better in just giving drugs, or think about how we can get this brain clearance better after subordinate hemorrhage.
Yeah, just in case this neuron activation, neuronal system is good, but I think that some astrocyte impairment also change the vasodilation, vasoconstriction, and I think that also might influence these cases.
Yeah, just because of the inflammatory reaction. I mean, the astrocytes are activated because of the inflammatory process that occurs. And even the microglia is changed. You get more microglia. And this is really, it's a complex, really a complex of things that are happening. It's not only that you have one vessel occluded and you have to open it and everything is fine afterwards. That's the reason why I really think about if like aggressive treatment of only the proximal arteries is really the right way to overcome this.
Thank you.
Thanks so much. One quick question, very quick question.
Okay, we know that when there's a surgical clip and calling may cause metabolic artifact. So
Yes.
when the patients underwent perfusion scan after surgical treatment or calling, do you think the CT or MRI is a better choice
So the MRI would be the better way because you don't have these crazy artifacts close to the eclipse and But as I already explained, it's really a measure of sources that you have to offer an MRI. Yeah.
I want to thank you also for brilliant talk. And
Thank you.
when I've explained in the beginning how capillary changes creates shunting of oxygenated blood. And if you think of it, the only way to limit that shunting to get the oxygen out in the tissue is actually to limit blood flow. And we wrote a opinion paper back in 2014 about how vasospasm actually and changes in cortical spreading depressions actually fit the bill of something that begins by being capillary flow disturbances, and then to limit flow sort of ascends up to. And having realized that, we looked in animal models to see whether there were capillary disturbances already immediately after the hemorrhage, which we found already on day 1. So that's why your data you showed here were so exciting to me, to see that increased OEF, which is sort of an ischemia that tissue generate, maybe one that is generated to maintain oxygen, is actually there. And your advice to get early images day 1 is so important.
Thank
Because
you.
it ought to be there if that's the way it is. But thank you so much for a very inspiring talk and a very nice overview. Thank you.
So hopefully next year we even have more information about it.
That would be wonderful. Thank you so much.
Thank you.